Hello, ladies and gentlemen. Welcome to Triple N Media Cardiology Seminars. I am Dr. Nik Nikam. At the end of my presentation, I'm going to tell you how you can get Cardiology Rotations Manual, more than 170 pages for free. The feature presentation for this seminar is Takotsubo Cardiomyopathy or broken heart syndrome. It was first described in 1990 in Japan. It is characterized by left ventricular apical ballooning during left ventricular systole due to diffuse left ventricular hypokinesis and myocardial stunning. It is called Takotsubo because it represents a Japanese octopus called Takotsubo in the appearance that we see on an echocardiogram or a left ventriculogram. It is related to excess catecholamine release, which leads to coronary artery spasm. Also, the effect of catecholamines on the myocardial cells or the myocytes, leading to myocardial damage, is similar to a presentation we see in patients with pheochromocytoma. The characteristic feature is, of course, bulging of the apex of the left ventricle, including the mid segments, sparing the base of the ventricle. Normally, during systole, you expect the ventricles to contract, so the cavity size is small and the apex is squeezed to a considerable degree. But in a patient with Takotsubo syndrome, you see an hourglass appearance like this with little tentacles representing the cardiac structures. Hence the term Takotsubo syndrome or broken heart syndrome. Where did the word broken heart come from? That relates to the etiology of this Takotsubo syndrome. It is seen predominantly in Caucasian females between the ages of 65 to 80 years. African Americans account for about 4.4% and the Hispanics account for 4.3%. 90% of these cases are seen in postmenopausal women. Some of the salient features of Takotsubo syndrome include middle-aged women, as I mentioned. There is an underlying history of anxiety, depression, or nervousness. Many of these people are being followed by psychiatrists and are on treatment. Takotsubo syndrome happens immediately following a very stressful event in life, like death of a family member or spouse or a child, accidents, financial crisis. Physical trauma is more seen in men as opposed to emotional trauma, which is more common in the women's group. It is characterized by typical chest pain, shortness of breath, weakness, fatigue, exhaustion. Physical examination may show evidence of some irregular heartbeats, maybe some evidence of heart failure. The biomarkers, troponins, will be elevated. We may see some new STT changes with the even presence of Q waves. It is seen in the absence of pheochromocytoma or an acute myocarditis. If we rule out pheochromocytoma and acute myocarditis, if the patient is having this apical bulging involving also the mid segments during systole, along with the symptoms that I talked about, we should always consider the possibility of Takotsubo syndrome. If you look at the myocardial biopsy of patients with Takotsubo syndrome, they show all signs of catecholamine toxicity. There are contraction bands seen, inflammatory cells, and some degree of fibrosis between the myocardial cells or myofibrils. Electrocardiogram can show features typical of an acute myocardial infarction with ST elevation and T wave changes and possibly Q waves. There may also be ectopic beats along with some irregularities in the heart rhythm. There are various types of EKG changes that we may see in patients with the Takotsubo syndrome, anywhere from an acute myocardial infarction pattern to minor T-wave changes or symmetrically inverted T-wave changes. Here we can see ST elevation with T-wave inversion. Here we have a deeply inverted T-wave. Here we have some non-specific ST changes. There could also be prolongation of the QT interval or the PR interval. So these are some of the electrocardiographic features, the most common of which is the ST elevation and T-wave inversion. Echocardiography is very useful in diagnosing Takotsubo syndrome before we proceed to cardiac catheterization. Echocardiography, especially in four-chamber view, can show this abnormal apical bulging along with hypokinesis of the apex and the mid-segment, and we may also see some evidence of a thrombus, especially if we use contrast to differentiate the wall from the thrombus. Along with that, we're going to have increased left ventricular volume. There may be mural thrombus, dilated ventricle, and of course reduced ejection fraction. The ejection fraction can range anywhere from 20 to 45%, the normal being 55 to 70%. Angiographically, the coronary arteries may look normal. There is diffuse hypokinesis of the apex involving the mid segments, as I told you, the anterolateral and the inferior walls, and of course there will be reduced ejection fraction. Complications. Because of this apical hypokinesis, these patients can develop classical features of left heart failure with pulmonary edema, which is seen in approximately 16% of the cases, arrhythmias noted in about 15% of the patients, and cardiogenic shock in approximately 10% of the patients. An interesting point is that there is almost a 10% recurrence rate. That means recurrence of this Takotsubo syndrome in patients who had an episode of Takotsubo syndrome. And of course, I mentioned the left ventricular thrombus. And the treatment is, of course, symptomatic treatment for chest pain, shortness of breath, pulmonary congestion. Of course, we address heart failure regimen if it is needed, with evidence of reduced ejection fraction and wall motion abnormalities and cardiac enlargement. Antiarrhythmics if the patient is experiencing irregular heartbeats, and psychiatric counseling and follow-up needs to be done. This is something that's sort of put in the back burner, I would say, when patients are in the hospital, but this is something that has to be set up before the patient leaves the hospital if there is a previous history of psychiatric problems, or if there is current evidence of emotional problems precipitating the Takotsubo syndrome. Prognosis is fairly good. There is symptomatic improvement within a week or two, and most of them recover by 3 to 4 weeks. There is a 10% recurrence rate which needs to be kept in mind, and these patients need to be followed in the clinic on a regular basis to address their cardiac problems and also address their psychiatric needs. In summary, ladies and gentlemen, Takotsubo cardiomyopathy is something that resembles a Japanese octopus, the manner in which the left ventricular function is deformed with apical hypokinesis, dilatation, and the hypokinesis of the mid segment, causing this like a flower pot appearance with these little tentacles, and it is driven by emotional or physical stress, leading to excess catecholamines beta 1 and beta 2, which acts on the myocytes and causes the heart dysfunction, leading to myocardial damage. It is generally seen in middle-aged females, especially with a history of some psychiatric problems, and there is apical ballooning and myocardial injury with a fairly good recovery rate. So ladies and gentlemen, you have been watching cardiology seminars brought to you by NNN Media. And if you would like to get a copy of my cardiology rotations manual, please do send me an email at drniknikam@gmail.com. and I'll be very happy to send you this one. And please do subscribe to our YouTube channel. We have more than 200 cardiology lectures on our YouTube channel, and please do watch them, and we will see you in the next video.